management of co-infections. So when we are thinking of managing patients who have Pneumocystis pneumonia, we always have to remember the significance of co-infections. And the reason this is very important is because it's common. Co-infections are very common with Pneumocystis pneumonia, and typically what will happen is that you have a pediatric patient presenting with a lower respiratory tract infection who doesn't improve on the initial antimicrobial agents that they've been put on, and then that's when the thought of this being something else, a fungal infection with Pneumocystis pneumonia, perhaps occurs. Now, it can happen, the co-infections can actually be present at initial presentation, or in patients who have severe infections with Pneumocystis pneumonia who then end up in critical care units, then they end up acquiring hospital-acquired infections when they are in the hospital, either in general wards or in the critical care units. Co-infections are a frequent cause of clinical failure, and so when you have a patient that you're managing and they're not improving, then at the back of your mind you need to be asking, is this a Pneumocystis infection with something else, or is this a Pneumocystis infection that's not responding to the antimicrobial that you're giving? Now, in a pool of about 1,400 patients from 49 studies, the co-infection bias is of course towards respiratory pathogens. Now, what are these co-infections in Pneumocystis pneumonia? So you could have bacterial infections, and the commonest of the bacterial infections are Staphylococcus aureus, Streptococcus pneumonia, and Klebsiella. For the viruses, you may have RSV, adenovirus, or Cytomegalovirus, and you could also have Mycobacterial tuberculosis. Now, in the non-HIV infections, similar to the in the non-HIV infected, similar to the HIV infected, you also have mainly pulmonary co-infections, and these have been found to be present in from 1/4 to 3/4 of the patients. Multiple pathogens have been isolated: Staphylococcus aureus, gram-negative bacteria, Aspergillus species, and Cytomegalovirus. In patients who have received, in a subset of patients who have received stem cell transplants, Pneumocystis pneumonia was associated with Cytomegalovirus pneumonia in around 50% of the patients. So let's narrow into the viruses. Viruses are present in about 16 to 40% of HIV-infected children with severe pneumonia from whatever cause. And the commonly isolated viruses will be respiratory syncytial virus, influenza, human metapneumovirus, and increasingly in sub-Saharan Africa, Cytomegalovirus is being identified. Now, it's difficult to make a diagnosis out of research settings for virus causes of pneumonia, especially in low and middle income areas. And the other really big problem when a virus is isolated is finding out, is this really a pathogen or is this just a colonizer? Now, in autopsy studies, Cytomegalovirus co-infection has been reported in HIV children and in 1 out of 5 adults who have a respiratory tract infection in autopsy studies. Now, the CMV infection causing a pneumonia is more common in HIV infected than uninfected children, and it could be an indicator of immunosuppression, where when Cytomegalovirus infection is isolated, then you're probably dealing with a patient who has a higher degree of immunosuppression than where it is not. CMV viremia usually peaks around 3 to 6 months, and it's, as I said, it's been found in higher proportion of the HIV-infected children, and interestingly, also in HIV-exposed pneumonia, even after adjusting for the HIV infection. It can be CMV detectable DNA can be an independent predictor of HIV transmission and mortality. In the pre-ART era, there was about 50% co-infection with PCP and about 36% dual infection in patients who are ventilated. And this is all to say that when you have a ventilated PCP pediatric patient who is failing treatment, then you should be thinking about a cytomegalovirus pneumonia. Histological diagnosis is sometimes required because its role in pulmonary disease is sometimes difficult to assess. So sometimes biopsies need to be done to find out if the CMV that is being detected in blood is also present in the lungs. When it comes to bacterial co-infections, as we have already said, Pneumocystis pneumonia is a co-infection of bacterial pneumonia, and as we know in children, whenever you have polymicrobial disease from whatever cause, then a higher mortality is found. Blood culture with appropriate antibiotics is of course necessary, because not only would the bacteria be found in the lungs, but the bacteria could also be found in blood. Now, higher rates of resistant bacterial organisms have been found on nasopharyngeal swabs in association with PCP in children. The commonly isolated bacteria are Streptococcus pneumonia, Staphylococcus aureus, and gram-negative bacteria like Klebsiella and Escherichia coli. Tuberculosis co-infection is one of the big ones, because there's been a lot of debate about putting patients who have Pneumocystis pneumonia on steroids, on cotrimoxazole and steroids, when you have not been able to rule out TB. And what we have to remember about tuberculosis is that it can present as an acute severe pneumonia in infants and young children, and it's true that steroids have the potential to worsen untreated tuberculosis. Another important thing to remember is that when you take gastric washings or induced sputums, which are routinely done for tuberculosis diagnosis, then the same specimens can actually be presented for microscopy for Pneumocystis pneumonia, and help you to find out which of the two is involved in this child, or is it both of them at the same time in the same child. Now, when you look at the literature to try and find out how many PCP patients actually have been found to have, how many TB patients have actually been found to have PCP, then in this study of 2,600 patients, we found about only 5% of the patients who had TB had PCP as well, and the PCP diagnosis in this study was made based on microbiology and also presumptive. So there is, and this study was found in was done in a high-income country. So basically, there is data missing on in low and middle income countries, knowing that we have a high TB burden, to try and find out what are the co-infection rates of pneumocystis and tuberculosis. How many patients who have pneumocystis pneumonia also have tuberculosis, or how many in a cohort of patients who have tuberculosis, what percentage of them might have pneumocystis pneumonia. And this is really important, especially when you're thinking of steroids, because they have the potential to worsen undiagnosed and untreated tuberculosis. So in summary, Pneumocystis pneumonia commonly occurs as a co-infection, and other than bacterial co-infections, which we obviously know about, Cytomegalovirus pneumonia is increasingly being reported in pediatric patients, and co-infections confound both diagnosis and management of Pneumocystis pneumonia.